Hello everybody. Am I audible to everybody? Welcome to Heart Failure Live. Myself Dr. आशीष कुमार. हार्ट फेलियर के बारे में हम लोग हमेशा बहुत सारी बातें सुनते हैं कि हार्ट का पंपिंग वीक हो गया है और उससे ट्रीटमेंट भी हर आदमी के अलग अलग रहते हैं. कुछ लोग बोलते हैं कि ये मेडिसिन से फाइनल, कुछ लोगों का बोलना है कि स्पेशल केस में करा ली. समटाइम ट्रांसप्लांट की बात होती है. In today's discussion, we are going to take the point जो पेशेंट के सिम्टम, मेडिसिन और क्या क्या ऑप्शन रहते हैं अगर मेडिसिन फेल करती है तो हार्ट फेलियर में जो सबसे इम्पोर्टेंट सिम्टम होता है वो होता है ब्रेथलेसनेस, सांस का फूलना. तो सांस का फूलना रेस्पिरेटरी डिजीज में भी होती है या पेट में अगर बहुत ज़्यादा गैस भर जाए उस समय भी थोड़ा बहुत सांस फूलना रहता है. तो हमको कैसे पता चले कि ये हार्ट का जो सिम्टम है वो हार्ट के कारण हो रहा है या लंग्स के कारण हो रहा है या कोई अलग कारण है, जिसको कहते हैं साइकोलॉजिकल हो जाए. तो हम लोग कहते हैं ब्रेथलेसनेस ऑन एग्जर्शन, DOE और डिस्निया ऑन एग्जर्शन, दो टर्म्स हम लोग यूज करते हैं. और इस टर्म में जो सबसे इम्पोर्टेंट बात है कि ब्रेथलेसनेस मतलब सांस फूलना जो हार्ट के कारण है उसमें दो चार इम्पोर्टेंट फीचर्स रहते हैं जो कि हम लोग को पता करना होता है या जिसके बारे में हम आज डिस्कस करेंगे. नंबर 1, पेशेंट को अगर काम करते समय जो एक पर्टिकुलर वर्क था जिसमें इजीली वो लोग कर पा रहे थे और ऑल ऑफ ए सडन वो काम उसको करने में दिक्कत हो रही है या सांस फूलना शुरू हो गया, तो ये माना जाता है कि ये हार्ट के कारण हो सकता है और कुछ जांचें आगे करनी होती है. जांच से हो सकता है कि ये हार्ट के कारण है. दूसरा रहता है अगर पेशेंट को पैर में सूजन आ रही है. पैर में सूजन आना कभी कभी मेडिसिन के कारण भी होता है, लेकिन सांस फूलने के साथ अगर पैर में सूजन आ रही है तो ये, और जो कि पहले से हार्ट के मरीज हैं या कार्डिक पेशेंट है, उसमें ये एक सिम्टम लिया जाता है कि वो हार्ट फेलियर के सिम्टम्स हैं. तीसरा चीज रहता है कुछ लोगों को रात में उठ उठ के बार बार यूरिन जाना, मतलब हार्ट के पेशेंट है, सांस भी फूल रहा है और बीच बीच में सूजन भी आ रही है और रात के टाइम में जाकर यूरिनेशन हो रहा है खासकर दिल्ली में, तो ये भी एक हार्ट फेलियर के सिम्टम्स है. सो हम लोग के पास जो फर्स्ट लाइन ऑफ ट्रीटमेंट रहता है वो हम लोग कहते हैं मेडिसिन. उसमें 4 तरीके की मेडिसिन हम लोग जो प्रिफरेबली पेशेंट्स को देते हैं, जिसमें बीटा ब्लॉकर जो सबसे इम्पोर्टेंट रहता है, डायरेटिक यूरिन वाली मेडिसिन जिसको कहा जाता है, उसमें 2 तरीके की रहती है. इसमें 2 तरीके की और मेडिसिन ऐड हो गई है जो कि पेशेंट की सिम्टम्स को भी घटाती हैं प्लस उनके लाइफ को भी प्रोलॉन्ग करती है. एक हम लोग उसका नाम आर्मी के नाम से बहुत सारे पेशेंट ले रहे होते हैं जिसको डिफरेंट डिफरेंट कंपनी के नाम से आता है, आई थिंक दैट नॉट टू डिस्कस। और तीसरा रहता है पेशेंट का सोने के टाइम में, ये एक बहुत इम्पोर्टेंट सिम्टम रहता है कि सोने के टाइम में वो एक बैग एक उठ के बैठ जाते हैं और बोलते हैं कि हमको इतना सफोकेशन होती है, हमको 10-15 मिनट वेट करना पड़ा, उसके बाद सांस फूलना धीरे धीरे करके कम हो गया। इसको हम लोग टेक्निकल लैंग्वेज में कहते हैं PND, पैरालिसिस नॉक्टर्नल डिस्नी। ये भी एक हार्ट फेलियर का एक बहुत इंपॉर्टेंट सिम्टम है। और किसी मरीज को अगर ऐसा हो रहा है, मतलब पहले से हार्ट के मरीज हैं और साथ में सोने के टाइम में, सोने के कम से कम आधे से 1 घंटे के बाद एक बैठे उठ जाते हैं और विंडो खोल लेते हैं, या कह सकते हैं कि सफोकेशन इतना होता है कि उनको थोड़ा सा बैठना पड़ता है टू गेट द फ्रेश एयर, और ये उसके बाद ब्रेथलेसनेस कम होती है। ये भी एक बहुत इंपॉर्टेंट सिम्टम है हार्ट फेलियर का। एक सिम्टम आता है ऑर्थोपेनिया, मतलब बैठने में कोई दिक्कत नहीं, जैसे ही सोएंगे उनको सांस फूलना शुरू होगा। और इस तरीके के मरीजों में 2 या 3 तकनीकों का भी इस्तेमाल करना वो लोग शुरू कर देते हैं। ये भी एक हार्ट फेलियर के सिम्टम्स में आता है। तो हम लोग कहते हैं नंबर 1 ब्रेथलेसनेस, चलने फिरना जो कि पहले नॉर्मली कर पाते थे उसमें सांस फूलना शुरू होता है। दूसरा नंबर 2 जैसे पीरियड एडिमा, पैर में सूजन आना शुरू हो गया या पेट फूलना शुरू हो गया, दोनों दोनों सिम्टम हो सकते हैं। तीसरा रहता है रात में सोने के टाइम में सांस फूलना, मतलब सोते सोते उठ के बैठ जाना जिसमें सांस फूल रहा है। और चौथा रहता है ऑर्थोपेनिया, तकिया जो पहले 1 या 2 लगाते थे, अब उससे 3-4 उनको बैठ के सोना पड़ता है। ये चारों सिम्टम जो रहते हैं हार्ट फेलियर के सिम्टम्स है, बहुत इंपॉर्टेंट सिम्टम। ये सब सिम्टम जब फुल ब्लोन हार्ट फेलियर हो जाता है तब आते हैं। बट ऐसा भी हो सकता है कि पेशेंट को ये सारे सिम्टम्स ना हो, या पहले से हार्ट फेलियर था, रिकवर कर गया तो सब ठीक है। उनमें कौन कौन से सिम्टम्स आएंगे? तो उसमें जो सबसे इम्पोर्टेंट सिम्टम रहता है कि पहले लॉस ऑफ एपेटाइट, मतलब भूख थी वो कम हो जाएगी और पेट में ऐसा लगेगा कि हमेशा भरा भरा है, मतलब पहले बहुत अच्छे से खा रहे थे, ऑल ऑफ ए सडन धीरे धीरे करके उनका खाने की क्वांटिटी घटती चली गई और उनको लगता है कि पेट पूरा भरा पड़ा है। तो ये भी एक कंडीशन है जहाँ पर हम लोग मानते हैं कि हार्ट का पंपिंग वीक हुआ है, जो पहले था उससे कुछ कम हुआ है। और पहले पेशाब बहुत ज़्यादा बार आना नाइट में, लेटर ऑन पेशाब का कम होना, तो दोनों सिम्टम हार्ट फेलियर के कारण ही रहते हैं। लेकिन हाँ, यूरिन का कम आना सूजन के साथ खराब माना जाता है। ये एक ऐसा सिम्टम है जिसमें ऑल ऑफ ए सडन पेशेंट को बैठे बैठे भी सांस फूल सकता है। तो इसके होने से पहले तो भी हम लोगों को पेशेंट को हॉस्पिटल लेके जाना या डॉक्टर से मिलाना ज़्यादा इम्पोर्टेंट होता है। अब जहाँ तक रही ट्रीटमेंट के बारे में, तो ट्रीटमेंट में जो सबसे इम्पोर्टेंट ट्रीटमेंट रहता है मेडिसिन, जो अभी हम बोले कि 4 मेडिसिन बहुत इम्पोर्टेंट है, बीटा ब्लॉकर, AC इन्हिबिटर, आर्मी, डायरेटिक, और ये 4 ड्रग्स हर पेशेंट्स को दिए जाते हैं अनलेस और अनटिल उनकी किडनी का कोई प्रॉब्लम हो। इसके अलावा अगर ये दवा देने के बाद उनका सिम्टम्स घट जाते हैं या नॉर्मल डे टू डे लाइफ में कोई दिक्कत नहीं आई, देन उस मेडिसिन को हम लोग कंटिन्यू रखते हैं। कुछ मरीजों में ये मेडिसिन लेने के बावजूद भी पेशेंट्स को सिम्टम्स आते रहते हैं, मतलब हम लोगों ने दवा दिया कुछ दिनों तक के लिए, मान लीजिए 6 महीने से 1 साल या 2 साल उनके सिम्टम्स घटे रहे, बट ओवर द टाइम धीरे धीरे करके उनके सिम्टम्स बढ़ने लगते हैं। उस दौरान में हम लोगों को कुछ इन्वेस्टिगेशन करने होते हैं, और वो इन्वेस्टिगेशन में जो सबसे इम्पोर्टेंट इन्वेस्टिगेशन रहता है पेशेंट का ईको और ECG। और ये 2 ऐसे इन्वेस्टिगेशन है जहाँ पर हम लोग देखकर ये बता सकते हैं कि हाँ, ये पेशेंट्स को हम लोग डिवाइस थेरेपी में स्पेशल तरीके के पेसमेकर होते हैं उनको लगाया जा सकता है। तो पेसमेकर जो रहते हैं यूजुअली हार्ट बीटिंग जब कम रहती है वहाँ पर लगाए जाते हैं, लेकिन हार्ट में अगर वीकनेस हो या हार्ट की पंपिंग वीक हो गई तो उसमें भी पेसमेकर को लगाया जाता है। उसको उसके लिए स्पेशल पेसमेकर भी हम लोग CRT करते हैं। तो वो थेरेपी के बारे में भी सोचा जाता है। और ECG में कुछ ऐसे फीचर्स रहते हैं जो हम लोग कहते हैं लेफ्ट बंडल ब्रांच ब्लॉक में। ECG में आप अगर डायग्नोसिस में भी देखेंगे ऊपर में कहीं लिखा रहता है नॉर्मल ECG लेफ्ट बंडल ब्रांच ब्लॉक। ये एक फीचर होता है जिस पर हम लोग हर पेशेंट को डिसाइड करते हैं कि हाँ, पेशेंट का पंपिंग भी वीक है और इजेक्शन फ्रैक्शन भी कम है ऑन दैट, एंड ECG में भी कुछ प्रॉब्लम है जो कि इलेक्ट्रिकल है जिसको करेक्ट करने में पंपिंग बढ़ सकता है। तो ये एक पार्ट रहता है। तीसरा जो इम्पोर्टेंट पार्ट रहता है पेशेंट के लिए, जो जो हम लोगों को पता है कि नहीं, कोई भी डिवाइस थेरेपी हम लोग जब पेशेंट रिकवर कर जाता है या पेशेंट सोने वाली स्थिति में तो उसी में लगाते हैं, मतलब ही कैन बी एबल टू टॉलरेट लाइन फ्लो पोजिशन, और ये सारे मिनिमली इन्वेजिव प्रोसीजर्स होते हैं। डिवाइस छोटा सा रहता है जो कि हम लोग स्किन के अंदर में डालते हैं, और उसको फिर हम लोग उसकी जो तारे रहते हैं हार्ट के 3 चैम्बर्स को रीसिंक्रोनाइज करने के लिए लगाए जाते हैं, जो कि राइट वेंट्रिकल, राइट एट्रियम एंड लेफ्ट वेंट्रिकल में लगाते हैं। उसके बाद इलेक्ट्रिकल सर्किट्स को हम लोग रेक्टिफाई करते हैं, उसके बाद पंपिंग बढ़ता है। तो ये तो हुआ डिवाइस थेरेपी। लेकिन कुछ पेशेंट्स को डिवाइस लगाने की हम लोगों के पास ऑप्शन में, तो में ऐसा इलेक्ट्रिकल प्रॉब्लम होता ही नहीं है, और उस कंडीशन में मेडिसिन के बाद हमारे पास हम लोग उसका या फाइनल ऑप्शन जो रहता है वो होता है कार्डिक ट्रांसप्लांट। और कार्डिक ट्रांसप्लांट एक प्रोसीजर है जिसमें हम लोग पेशेंट के हार्ट के चैम्बर्स को लोग चेंज करते हैं, मतलब चारों चैम्बर्स को हटा के नया चैम्बर जो डोनेटेड हार्ट रहता है उसको लगाया जाता है। पहले 1 या 2 महीने की जो प्रक्रिया रहती है या जो फॉलोअप रहता है, थोड़ा सा शॉर्ट इंटरवल पर रहता है। लेकिन 3 से 4 महीने होने के बाद पेशेंट का जो लाइफ जो नॉर्मल पहले था उसी तरीके से रहता है। और अगर आपने किडनी के पेशेंट को अगर देखा हो तो लगभग सब कुछ वैसे ही रहता है। इसमें भी पेशेंट की पंपिंग क्षमता नॉर्मल हो जाती है, ही कैन डू द नॉर्मल लाइफ। कुछ मेडिसिन उनको लेना होती है कुछ पर्टिकुलर टाइम पे, एंड ही हैज टू बी ऑन द फॉलो अप। तो जो वीक हार्ट रहते हैं उसका ये फाइनल ट्रीटमेंट रहता है। अब आपको इससे रिलेटेड एनी क्वेश्चन, एनी क्वेरीज यू कैन आप लोग पूछ सकते हैं। मैंने ये सब चीज़ हिंदी में बोला, अगर आप लोग इसको चाहते हैं कि मैं इंग्लिश में बोलूँ या तेलुगु में बोलूँ तो मैं प्रयास जरूर करूँगा। मेरी आवाज़ आप लोगों तक पहुँच गई है? ये मेरा पहला, this is my first video, so I am not very much comfortable to make the changes even. अगर आपको आपके कोई क्वेश्चन हो तो आप यू कैन टाइप इट, यू कैन जस्ट रिप्लाई दैट। Now दूसरा जो लेट मी कम रिगार्डिंग दिस पेशेंट्स प्रोटोकॉल्स जो बहुत इम्पोर्टेंट रहता है किसी भी पेशेंट जो हार्ट फेलियर को हम लोग डायग्नोस करते हैं। तो डायग्नोस्टिक इवैल्यूएशन में जो सबसे इम्पोर्टेंट डायग्नोस्टिक टूल होता है वो होता है इको। ईसीजी और इको किसी भी हार्ट डिजीज के सबसे वन ऑफ द मोस्ट इम्पोर्टेंट इन्वेस्टिगेशन। So if you really want to label any patient who is having heart failure, that is the echo. And most of the time, echo parameter which is most important is the ejection fraction. So there are two type of heart failures that we deal, and the commonly discussed in most of the forum is the heart failure with reduced ejection fraction, heart pumping which is weak, एंड इजेक्शन फ्रैक्शन मोस्टली जो नॉर्मल मरीजों में, नॉर्मल पर्सन में जो हार्ट फेलियर का जो पंपिंग जो हम लोग मेजर करते हैं वो लेफ्ट वेंट्रिकुलर इजेक्शन फ्रैक्शन से नोट डाउन करते हैं, एंड दैट इज यूजुअली 55 प्लस होता है। तो इसको हम लोग 3 ग्रेड्स में डिवाइड करते हैं, दैट इज माइल्ड, मॉडरेट एंड सीवियर। इफ इट इज मोर देन 55 we take it as a normal, 45 to 55 we take it as a medium, and less than 35 to 45 is moderate, and less than 35 is taken as severe. This ejection fraction, which we take as one of the parameters for severity, this is not a very fixed parameter. It is a dynamic. Over the time, it can increase, it can reduce, and that become very very important. That who is measuring. So sometimes different lab on the same day give a different value. So ejection fraction is not a thing that we should get too much worried. Yes, it is one of the important parameters which defines the treatment protocol. And ejection fraction is dependent on two things. One is the patient that that their general condition. If he is having intercurrent illness, it may deteriorate for some time. Means patient is having infection and who is already having heart failure patient. So ejection fraction will drop all of a sudden from maybe it is 40% may go to 30, 35% or even 20% also for some time. And when the patient has recovered from the acute illness, it will again improve. So this is a very dynamic parameter, and we should not get totally worried if patient is having low ejection fraction. Low ejection fraction is one of the markers that the severity of the disease is improving or deteriorating. The second important part is whether the valve is leaking or not. That we call as a mitral regurgitation. और heart के chambers कैसे हैं? How is the heart chambers? Whether it is dilated or whether it is normal. So some patients in which patient develop myocarditis, which was very common during the corona time. Patient chamber size was normal. They have having a very weak heart, LVEF, or we can say LV ejection fraction was very low. And later on, they recover from the condition. So ejection fraction which is low during myocarditis can deteriorate over time. It may partially recover or it may fully recover. So for the patient who are for the first time been diagnosed with heart failure, let us understand what basically heart failure is. So heart failure is impairment of the heart pumping. Means the pumping which for a normal person he can go out of way and he can work hard and without any symptoms. If the heart pumping is getting weak, we call it impairment of the pumping. Means he can do all the job, but on some symptoms. Means he will start pulling the blood in the lungs because heart is not able to pull the blood in the whole systemic circulation. And in that situation, patient will be having symptom of breathlessness. And that's why I was saying breathlessness is one of the most important complaints that we should look. If a patient who is already been stented, if a patient who is already having heart disease, heart failure has developed, and he is developing again, time and again, breathlessness. Breathlessness is ISM, what we call as in the Telugu language. So if it is coming, it is a symptom of heart failure. And depending upon the type of heart failure, it may be possible that if ejection fraction is poor, we call it a heart failure with reduced ejection fraction, and if the heart failure, ejection fractions are normal, we call it a heart failure with ejection fraction. एक बहुत इम्पोर्टेंट क्वेश्चन हमेशा हम लोगों से पूछा जाता है कि क्या खाएं, हाउ मील शुड बी टेकन, हाउ मच मील शुड बी टेकन, हाउ मेनी टाइम इट शुड बी टेकन, वेजिटेरियन, नॉन वेजिटेरियन, salt and water, how many liters we should take of water. So let me make the things very easy for everybody. You can take everything. There's nothing like that. If you have developed heart failure, you should totally take out some of the meals. But yes, there are some what we call a salt-rich products like pickles, papas, ready-to-eat food, fast foods, or the food which is very enriched with the salt. So those food we have to avoid as much as possible, because if you are taking more salt, it will be going to retain water, and if it is going to retain water, it is going to increase the fluid in the body. And if it increased fluid is coming to the heart, it has to push a lot, it has to work harder, and the chances of again heart failure will be more in that case. Coming to the fluid means how much water he should take. So different people are having different opinion. Somebody say okay you have to take only 1 liter, or some say it is 1.5 liter. Somebody say okay not more than 800. So there is a discrepancy, and we have to understand more fluid means more strain on the heart. But if you are urinating too much, by if the patient is taking diuretic or even यूरिन वाले मेडिसिन खाने के बाद उनको बहुत पेशाब हो रहा है, in that situation if you are taking less water you will get dehydrated and you will feel very much weak. So fluid you have to take according to your urine output. Means if you are pouring a lot of urine and urine output is almost 2 liters, then you can easily take 1.5 liter is basic minimum that you should take it. We should not take more than the what we are urinating. What is the norms we ask for the patient who are having heart failure. So that is one part. Fluid you can go 1.5, 2, and even sometimes 2.5 is pouring around 3 liters of urine. But important and the most important thing is that you have to see two things. Number one is the weight, and second is the how much urine you are pouring. If you are passing a lot of urine, certainly you can take more water. But if you are pouring less urine, you are getting pedal edema, means your leg is getting swollen. Then in that situation, you have to reduce the fluid intake. And if you are developing restlessness, this is alarming symptom. You should not take too much fluid, and certainly you have to report to your doctor as early as possible, because symptom of breathlessness and some fever edema, or you can say swelling in the leg or increase in the weight. So monitoring of weight is a very important thing. If you can monitor the weight on and off, you will be knowing how much weight gain is happening. If you are gaining weight over the time, certainly you will be landing up with the heart failure, or we can say decompensation. Means everybody who has recovered from heart failure because their heart failure is a compensated case, and then he is getting pedal edema and breathlessness. We call it he is going to decompensation. Means the heart is not able to take care for the pumping for the circulation. Means it is failing. One important thing regarding the food intake. So vegetarian, non-vegetarian, there is some difference. No doubt, vegetarian diet is better than non-vegetarian. But the spacing of diet is very spacing of food is very important. You should not take all of more food all of a sudden. Means if you are taking food, you should take. Pick one meal into 2 or 3 meals and take more frequently than taking more meal at a time. That is one part. Means आप खाने को डिवाइड कर लीजिए एंड उसको जितना हो सके मतलब कम कम बार बार लेना ज़्यादा बेटर होता है देन एक साथ ज़्यादा खाना. ये डायरेक्शन हम अपने सारे मरीजों को बोलते हैं और आई थिंक दैट इज वेरी इंपॉर्टेंट दैट एवरीबडी हैज टू अंडरस्टैंड दैट ज़्यादा खाना लेने पर जो पहला 2 घंटे का जो टाइम रहता है जिसको हम लोग कहते हैं एसिमुलेशन में खाना पच रहा होता है उस टाइम में कोई एक्टिविटी जब आप करते हैं तो आपको आपके हार्ट को वर्क करना पड़ता है एक्स्ट्रा. सर्कुलेशन आपका इंटेस्टाइन में ऑलरेडी बढ़ा हुआ है और उस दौरान में अगर आप कोई भी काम करते हैं तो आपका आपको सांस फूलना और हार्ट पर एक तरीके से स्ट्रेन आता है. तो जस्ट आफ्टर फूड 2 घंटे का टाइम 2 hours is a basic minimum in which you should not go to the bed also and you should not work anything or even you should not go for walk also. क्योंकि बहुत सारे लोग करते हैं बाद में उनको प्रॉब्लम होता है. तो ये एक चीज़ है. दूसरा चीज़ है मोशन के टाइम. मोशन और यूरिन के टाइम में बहुत सारे मरीज लोग एक हैबिट रहती है कि अगर मोशन नहीं हो रहा तो दम लगाते हैं क्योंकि बहुत अच्छा नहीं माना जाता है क्योंकि ऑल ऑफ ए सडन हार्ट के सर्कुलेशन में एक स्ट्रेन आता है. इवन कोरोनरी सर्कुलेशन जो होता है वो भी कॉम्प्रोमाइज होता है एंड थोड़ी देर के लिए हार्ट बंद होने के चांसेस भी रहते हैं. इसीलिए हम लोग हर मरीज को बोलते हैं कि अगर मोशन नहीं आ रहा है तो उसकी मेडिसिन लीजिए बट नेवर स्टे. So Mr. Naveen has asked, during COVID era, got paroxysmal atrial fibrillation and normal heart. So atrial fibrillation and normal heart में ये वेरी कॉमन मीन्स कोविड के टाइम में ये होना बहुत अब नॉर्मल नहीं है क्योंकि पेशेंट में कभी कभी हम लोग कहते हैं इन्फ्लामेशन होना और इन्फ्लामेशन में कुछ भी हो सकता है. पेशेंट का रिदम हार्ट रेट बढ़ भी सकता है घट भी सकता है और ये अगर कंडक्शन सिस्टम से इन्वॉल्व कर रहा है तो it may be faster. Means usually young patient will be having faster heart rate and old patient will be having lower heart rate. And atrial fibrillation in that time it is more related to the what is called inflammation. So if it is happening, we have to just wait and watch. Most of the time it will revert to the normal. And if it is on and off ongoing, then we have to evaluate the cause. आज के टाइम में the most important one of the factor is obesity. So obesity is one of the condition in which patient को stress obesity जो आपने बोल रहे हो episode of stress it will get activated or that time we have to just manage the treatable cause में patient को obesity है hypertension है diabetes है all those things have to be well controlled. And most important, if you are doing a lot of physical activity out of them, all of a sudden you have taken the gym exercises and you are too much pushing yourself, then also active position can come. If you are not sleeping properly in the night or you are not taking adequate sleep, then also it can happen. So that was regarding heart failure. And हार्ट फेलियर में भी एट्रियल फिब्रिलेशन होता है. जब एट्रियल फिब्रिलेशन हार्ट फेलियर में आता है कुछ कुछ मरीजों में ऐसा रहता है कि एट्रियल फिब्रिलेशन के कारण पेशेंट का हार्ट का पंपिंग वीक हो जाता है. Means the atrial fibrillation leading to heart failure. We call it tachycardiomyopathy. Means the pumping which is due to prolonged duration of atrial fibrillation. And in that condition, just we have to correct it by giving the medicine or sometimes by the shock therapy. The pumping totally improves. Means it becomes normal. So atrial fibrillation with heart failure, it is a totally a different entity. And sometimes we have to uh, give the therapy in form of DC cardioversion to make that to understand whether the rhythm disorder was responsible for heart failure or not. And even the hospitalization also reduces if the patient is having the rhythm normal. So that was Yes, BP, not the BP and sugar, but stress and anxiety. Yes, stress and anxiety is one of the precipitating cause for that paroxysmal AF. And paroxysmal AF is nothing, if you can understand, it is irregularly beating of the upper chamber. And if you are aware or not, upper chamber, the left atrium is having what you call a lot of nerves on the back side. So if the patient is having a lot of gastric irritation, or you can say GERD or gas sensation, he can develop atrial fibrillation on and off. And the time we control his gastric problem by giving the medicine, even the atrial fibrillation also gets controlled. Yes, flecainamide and bisoprolol is a good medicine to control it. It is a preventive medicine basically. Now we have discussed regarding the CF measure. One question has come from Ravi Kumar. Sir, CF is measured for LV. Is it measured for RV? We are always trying more on the all the chamber in connections. Sorry, all the chamber measurements. We are more confined to the left side than the right side. RV ejection fraction is not commonly measured, but yes, our we are having measurement by the echo. Left side is mostly utilized for the treatment and making the treatment protocol. But when the patient is having totally RV cardiomyopathy, means something which is totally confined to the right side of the heart, there we see the RV function. And if you want to know what is the measurement tool for that, you are having PAP, tricuspid annular uh, uh, measurement, means that is movement, how much it is having. So usually it is TAPC is around 21 plus. So if it is falling below 18, we say that there is RV dysfunction. So TAPC measurement gives the value regarding the RV dysfunction. For LV, we usually go by the EF only. And EF, if it is more than 55, it is taken normal. 50 to 55, it is taken as borderline. And usually 45 to 55 is mild. Or 35 to 45 is moderate. And less than 35 is taken as a minimum. That is called severe LV dysfunction. Yeah, Naveen, that what you are asking, that just now I told that GERD, IBS, and birthing, these all are interconnected. So just I was saying, left atrium is having a lot of nerves on the back side. So whenever any gastric irritation happens, that irritates the nerves on the left atrium. And whenever this left atrium nerves get irritated, it throws, we call as the APCs, atrial premature beats. And these beats are responsible for throwing again this atrial fibrillation. And IBS is one of the syndrome we call it that nerves in the gut are very much sensitive. For we can say the gut is very much emotional. So any emotional stress is happening, any sort of stress, physical, mental stress, all of a sudden the patient will start having the gut problem. His bowel may be having either constipation or diarrhea. So this is a mark that the nervous system, or we can say peripheral nervous system, is very much sensitive. And the same applies for the heart also. The nerves which are supplying the upper chamber of the heart is very much irritable. So in that situation also paroxysmal AF can happen. If you are having any question, you can drop certainly. And if it is not related to heart failure, if you are having anything else also you want to know, I'm happy to answer. So atrial fibrillation, whenever it happens, the most important thing that we have to know whether we are having any reversible cause or not. That is one thing. And the second important thing is whether we are having risk for developing stroke or not. So if you are having valve issue, what we call as like valve is leaking, or particularly valve is having stenosis, what we call as mitral stenosis. In that situation, you have to go for we call lifelong uh, anticoagulant, means blood thinner you have to take lifelong. And it is not aspirin or clopidogrel. It is anticoagulant, what we call as warfarin or apixaban or rivaroxaban. So those medicines are must in those patients. And if you are having atrial fibrillation and you are not having any other risk factor, so risk assessment we have to do. Chadwell scoring we call it. So if your Chadwell score is more than 2, means there are some parameters we check that these patients, if atrial fibrillation is happening anytime, they may be having more chances of developing this stroke. So that is a Chadwell score. And if it is less than 2, yes, you can just control the situation, or we can say we can preventive medicine, what most of the time we give beta blocker or some of the disease modifying agents. And if it is happening time and again, then we have to look for the cause, and sometimes we have to do the ablation. हार्ट फेलियर के बारे में मुझे लगता है लोगों को बहुत ज़्यादा ज्ञान हो चुका है. And there are something which is very common that हम लोग कहते हैं उसमें chest pain. तो chest pain को लेके हर आदमी बड़ा उत्सुक रहता है कि whether it is cardiac or not, और उनकी जिज्ञासा रहती है whether it is due to the heart or not. So cardiac pain versus non-cardiac pain, that is very important place which we should we have to differentiate. And any patient who comes to me, I always educate them also that you should know this pain is a cardiac pain, and there is no confusion regarding that. And just for everybody, for the sake of listeners, I just want to say that the chest pain of cardiac will be having something we call as a heaviness on the chest, and it radiates to the arms also. It can go up to umbilicus also, and sometimes up to the we can say jaw line also. So anything which is something which is you may not have got any time, or we can say something is pressing your chest, which is a very unique sensation. Most of the time, people are not having this. I'm having pain here, and it is all the time present, or it has got nothing, or sometimes I'm weak. So those pain are not. We can say that it is related to the cardiac. The cardiac pain is having a typical character because of the heaviness or something pressing. And the second important part is the time they start walking or doing any activity, it will increase. And when they will take rest, it will reduce. So when these 3 points are present in any patient, means he is getting heaviness, the time he walks, it increases, and the time he is stopping, it is reducing. It is a marker of cardiac pain. We call it angina. And if it is happening, then you have not to waste the time. You have to go to the earliest, wherever possible, nearby to the doctor or the center where the ECG can be done. And ECG will give a lot of clue whether you are having ongoing heart attack or not. So that symptom is very, very important. Then comes sometimes without pain, heart attack can happen. So there are subset of patients we call as diabetic, prolonged diabetic patients, elderly patients who are 65 or 70 plus, who are having CKD, kidney disease. So these type of patients, the nerves which lead this type of heaviness in the chest will not be active, means they will not get those type of symptoms, and they will start having breathlessness as a complaint, not as a chest pain or heaviness. They will have some sort of breathlessness or some sort of other symptoms like giddiness also. And in those symptoms, we have to keep our suspicion that he may be having heart attack. So patients who are young, who are not having these 3 type of condition, what we call it, prolonged diabetes, kidney disease, elderly 65 plus. So these These type of patients usually have usually are not having a typical chest pain. What I told angina, they may be having breathlessness is the main complaint, and sometimes giddiness also. So if your older patient is getting giddiness on and off, don't take it as a lightly that it is due to weakness or it is due to the age of the patient. It can be if he is not having earlier giddiness and he is getting giddiness which is not in the morning hours. Usually morning hours due to the we call as a vertigo that happens that everything is spinning outside. He is not having he is having a spinning sensation. So that is vertigo. That is a different thing, and that is related to the ear and cervical spondylitis. But the person who is while walking is getting breathlessness or all of a sudden he is getting sweating and giddiness. It is a symptom of heart, and nothing can give a clue other than the ECG and a good clinician who can examine properly and give the, do the echocardiography also in that time. That will give the direction that yes, he is having cardiac, what we call as a myocardial infarction. So these are the things which I thought it will help people to know regarding the cardiac problems, and if somebody in the family they are having, they should be alert and they should take care wherever possible to the nearest cardiac center or where the basic amenities are there to see the ECG and ECG. Because these are the two important tools which answer a lot of questions related to the heart problem. So ECG and echo if you are able to do, you will get the information whether he is having or not. Then comes regarding the trophy test. A lot of times people are not having any problem. They have gone to some other region and they told, and all of a sudden they will say that you are you are having trophy positive. Means you have gone to with some different type of chest pain, and all of a sudden they told that you are having heart attack by seeing the trophy. So yes, trophy is a very sensitive test, and it gives the information regarding what you call mm, whether the myocardium is getting injured and some of the parameter is spilling in the circulation, which we call as a trophy and trophy. But it can be falsely positive also, and in that situation, ECG, echo, and history means patient's clinical symptoms will guide whether he is having or not. So that is a very sensitive tool, and that is one of the part of the evaluation when we are not able to judge by clinical history that he is having or not. And as per our norms of vertical guidelines, sometimes we have to do in most of the patients of chest pain. So Vinay said also how frequently we need to go for the stress or 2D echo test if it is required for every 6 months or 1 year. So very good question. First of all, let me make the things clear. We are doing the echocardiography to assess the function status on that particular time. Function status means echo will guide two, three things. Number one, how the chambers are, means how the chamber size and how the valve are functioning, means whether any leak or any stenosis is properly going or not. Any congenital anomaly of the heart is there, means all the chambers are fine, or we can say there is a holes in the heart that will be detected by the echocardiography. And stress echo is one of the investigation we do in a selected patient, means the patient who can't do the TMT due to the knee problem. So, or we want the objective evidence that his coronary is normal. Coronary circulation is almost is having a normal circulation. So in that situation, we do the stress echo. So let us differentiate 2D echo, echocardiography are same thing. 3D is also available, but most of the time it is not needed, and it is a technically advanced echocardiography needed for the surgical point of view sometimes when we are planning. But echocardiography, 2D echo are the same thing. It is basically the sonographic evaluation of the heart. So by giving the sound and we are going to make the heart, how the chambers are, how the ejection fraction is, how the pumping is, whether valves are functioning proper or not, or any structural problem is there. Structural problem is heart is thick, heart is thin, heart is weak, heart is having what is called pumping is weak. So these things will be defined by the echocardiography. So ideally, one time it should be done when you are going for a general evaluation particularly if you are having ECG findings, which is giving some clue that you may be having any structural problem, or if you are hypertensive to see whether any end organ problem is coming. End organ means if you are hypertensive, the heart may get sick. So we have to define whether sickness is there at that particular time or not. Sometimes patients is having hypertension for 5 years, but heart is totally normal. So if it is well controlled, most of the time the heart will not become sick, and sometimes it may become sick within 1 year. So to define what is the baseline heart pumping, heart thickness, and the valvular status, and any other structural problem congenitally means which any holes are there in the heart or not, any valve is properly positioned or not. Those things we define by doing the echo. So one time echo done, there is no need of repeating every year or 6 months. Yes, patients of heart failure, it is needed at least yearly once. And if the symptoms demand, means all of a sudden 3 months he was doing fine, after 4 months onward is again developing. In that situation, it can be repeated to define what is the cause, what is the next reason for this symptom. So whether the valve is started leaking or something more is coming, and we have to know the status at that time, how much ejection fraction and how it is doing over the time with the medicine, whether it is improving, static or deteriorating. So stress ego we do for patients who are not able to do the TMT, or we are planning any surgery and we want that evidence that yes, all the coronary circulations look okay. So it is an indirect I give what you call findings in favor if one particular wall, you can say one particular area is not moving properly, then we can just suspect that we may be having coronary artery disease. Coronary block can be there in this particular. Hope Avinash, we got your answer. Yeah. So 2D echo, just we discussed 2D echo and echocardiography both are the same thing. And sometimes the patient gets very much worried for the ejection fraction. So ejection fraction is something which is not static. As I told that sometimes it will improve, sometimes it will deteriorate, sometimes it's mismatched with the symptoms. So you may be feeling better, but ejection fraction when it has been measured, it look like that it is dropped. So how your compensatory mechanism are working, that is more important than how the ejection fraction is doing. So we are left with around 12 minutes more to go. If you are having any more questions, you can certainly post on the chat box. Regarding one more complaint that sometime in the heart failure patient comes regarding the device therapy. Means they are a lot of people are told that your heart is weak and you need a ICD, implantable cardiac defibrillator, or automatic implantable cardiac defibrillator, which is a very costly device which costs around 6 to 7 lakhs for single chamber, and if you are going for dual chamber, 2 hours, it may be costing 9 to 8 to 9 lakhs. So let me explain those things that if the patient's heart pumping is weak and he is getting rhythm issues, or you can say there are some conditions in which uh, uh, heart is having some inherent disease in which the arrhythmia can happen. Situation putting ICD is a good choice because that prevent it. Works like a what we call safety mechanism to prevent the sudden cardiac arrest. So whenever what we do from the outside defibrillation, it can be done through that device also. So there is the highest protection we provide to the patient when they are having weak heart and and off rhythm issues are going on. Or the disease like there are some disease like hypertrophic cardiomyopathy or patient is having what we call Brugada syndrome. There are some conditions in which we can see by the ECG or the echo will say yes, you are having more electrical issues and in that putting AICD will be a better choice. Naveen has asked, sir, क्या EPS RFA करना चाहिए? So, Naveen, that regarding EPS RFA in the case of atrial fibrillation is something which is when medicine fails, we are getting a recurrent episode after controlling your risk factor. Means if you are having obesity, if you are having hypertension which is uncontrolled, or obesity which is uncontrolled, or you are having stress or something like uh, what you call sleep disturbances. In that situation, first we have to correct it. And there are some initiators. Sometimes the CT study will detect that this is the rhythm issue which is degenerating in atrial fibrillation. And when we do it, it will guide us. Okay, we are having one rhythm issue which can be curable. In that situation, yes, CT study should be done. What is the maximum heartbeat level we can reach during exercise? And if yes, if we can comfortable during exercise, what we need to do? Yeah. So this is also a very common query we get. So regarding the heart rate, 220 minus age. So if you are around 40, 220 minus age means around 180 you can easily reach. And as for our stress test, when we do it most of the time, our target is to reach around 80% of the same. So 220 minus 40, it is around 180. So around 85% of the heart rate we want to reach and level that time that when the person is doing GMT, he has reached to 85% of the heart rate and there is no ECG changes. So that is a mark that yes, his heart is having a good exercise bearing capacity and oxygen what he has to the heart has to receive, it is receiving adequately. There is no changes is coming in the ECG. Sometimes a lot of patients when they are going for the TMT or for the what we can say heart rate, all of a sudden increases. They are having 80 or 70 and in the stage one or two, in stage one only they are able to reach around 85%. So we call it that they are having a intolerance to the exercise or intolerance to the physical activity. So heart rate will fluctuate a lot. All of a sudden the heart rate will go high and they will become breathless. So that is the situation we call it is an intolerant physical activity of exercise, and the test may not be predictable for ischemia or we can say coronary shock. Yeah, if you listen. So if you are facing, let us make very clear. Exercise during exercise, if you are getting any uncomfortability, that can be two things. One is breathlessness, and second is chest pain. Either of these two things are marker of heart disease. And if it is not there earlier, then we have to evaluate from the cardiac point of view. If it was present and it is deteriorating, then also we have to check for the cardiac point of view. But if a person who has not worked for almost 6 months, he was doing everything, and then he started again doing to the same extent, then because the intolerance, his heart rate will not be able to cooperate for that particular work, and all of a sudden it will increase and he will get uncomfortable of that. So effort intolerance is different, and if you are doing same activity and leading to restlessness or uncomfortability is a mark of heart disease if it was not present earlier. There is sir, is it a permanent cure by the 3D ablation? So 3D, let us be very clear regarding atrial fibrillation and non-atrial fibrillation rhythm. Atrial fibrillation, whatever we are doing, it is basically for control. Basically for control. We are not going to cure it. In paroxysmal AF, sometimes if it is coming from particular one of the vertical pulmonary vein and it is spilling to the left extreme. In that situation, sometimes we are able to give some curative extent if it is initial part of the disease. But atrial fibrillation ablation is never a curative treatment unless it is PSVT, means paroxysmal supraventricular tachycardia, which is a different entity. In that situation, the heart rate will go up and down, and sometimes it degenerates into AF. In that situation, if you are going to ablate PSVT, it can be cured. But if it is a primary atrial fibrillation, means atrial fibrillation is the only illness, mostly it is not curable. It is just we are controlling it by doing it. And 3D ablation is just it is a variant of EP study. So it gives more clarity about the heart chambers and our movements of the catheters, where we are doing it with the 3D view of the catheters, which we are not able to do in the conventional EP study. So permanent cure of atrial fibrillation is not there if it is already set up. Persistent, it has gone more persistent, it is there, but it is basically a more rhythm disorder which we are still not knowing why it happens. And if we are not knowing why it is happening, it is more we are giving a control type of medicines. We are able to reduce the medicines after the so 3 minutes more. You are welcome. So I think with this we are coming to the end. Since it was our first YouTube live, and I was not very much aware regarding how to record it, and that initial part has not been properly. Nowadays, after using M-looking anti-MIDP normal, and shall I reduce the dose, or I need to same thing earlier? Yes, over the time we are certainly de-escalate, and sometimes we take out the medicine. We check for a time. We keep a watch how much the blood pressure is fluctuating. Our target is always 140/90 in a person who is not having kidney disease or diabetes. And if we are able to maintain with the diet and exercise, that is taken as a final for the person. But yes, BP is something which is not very static in one-time level, and one medicine has been given, it is going to work. So there may be fluctuations with the same medicines and the same dose. So what diet is good for healthy heart? So for healthy heart, the first thing is the positive mind. The fear factor, this should be out of the place anytime. So if you are having heart disease, you should be bold enough to face it, because heart and brain are very tightly interlinked. The time you are becoming fearful or you think negative, the disease start working against you, or the medicine even also not very much effective. Food point of view, it depends what type of disease you are having. If you are having coronary artery disease, we usually say that yes, everything you should take, but restricted. But diet is not that much important than the timing of diet, quantity of diet, quality of diet. If you are taking everything, just reduce the things. If you are having obesity, you have to reduce it. So Indian diet is the best diet if you are taking in the right quantity, and as minimum, and if you are doing properly spacing of the diet. keep the night diet as light as possible. That will certainly help you a lot. But there is no as such healthy diet. Indian diet, if you are taking, that is the healthiest diet I can say. And South Indian, that's the best. So thank you, Avinash, Naveen, Gayatri, Tipakar, Ananya, Ravi Kumar, and for joining us. And we are happy that we got to connect on YouTube. See you next time with new topic. Thank you, everybody.